to our Scale Up Blood Pressure webinar. I have to say this has been actually a long time trying to get this organised, because just as we've been trying COVID priorities went elsewhere. So it's really nice to meet everyone. Please, few housekeeping rules I'll tell you about in a minute, but I'd like to introduce Professor Brian McKinstry, who will be speaking to us. He's our National Clinical Lead for the Scale Up Blood Pressure meeting, and Richard Forsyth is from British Heart Foundation, so we have really strong links with Richard and his team in Scotland as well as in the UK, and we're welcoming him. I'm Morag Harty. Those of you who don't know me, I'm the National Lead for Remote Health Pathways, previously known as Home and Mobile Health Monitoring, and the Scale Up Blood Pressure programme's part of that. My other part and other hat is that I'm the Programme Manager for Tech in Lanarkshire, so welcome to everyone from across Scotland. You're very welcome today. I'd also like to introduce Joe McKee, who's the Project Manager for the Remote Monitoring Pathways programme from Scottish Government, and Tom Daly, Project Support Officer as well. So they're going to keep an eye. Joe's going to move on the slides for me, and we'll all be keeping an eye on the chat box. So next slide, thank you, Joe. So just some actual introductions here. The session will be recorded. If you do not wish that to happen and you want to exclude it from that, please let us know. You can put that in the chat box or privately message us. But that means we can share this later on. You can go back and share it with any relative, any colleagues who can actually want to see it in their own annual leave or whatever. Please do keep on mute unless you are speaking. And the same way we find usually if you switch off your camera, there's a number of people on the actual call that can reduce the impact on the bandwidth. So please, if you turn that off where you can, and again, put it on when you come into the chat, into actually answering any questions. There is a chat function there if you've got access to that, which is your hand raised, but we will be taking questions at the end, and we're trying to leave plenty of space for that as well. And as I say, if you then put your hand up if you're wanting to raise a question at the end, but we'll try not to sort of stop halfway through. We'll take notes of the questions there. I see someone's put a message on at the minute. I'm just going to see what that is. Let me move on now. Valerie, is there something else? Somebody else got their hand up? That now sorted. Blood pressure programme, as we've said, that started 2018, end of 2018 we launched this, and in 2021 we're moving forward there. So last year we sort of really started this the middle of last year. We've got 1.2 million in funding and some additional funding that was introduced as well. That helps. Does that help now? Yeah. Okay. Oh, sorry. Technology. It's all right. This is not a good day today. Okay. So National Scale Up Programme, 2018 to 2021. We've got 1.2 million funding that was launched by Gregor Smith way back in the winter of 2018, and we've moved on since then. 11 local partners. And I'll show you where they are. National protocols are there. We've developed those in partnership with our clinical leads. We've managed to get a document solution working where reports are going into Docman, and I'm pleased to say that in actual fact, Grampian are going to be the next board area that will be able to integrate that. They're under testing at the moment. And we produced a guidance pack, which we will certainly be doing a second iteration of very shortly. It should be said that that's the trajectory. We started off pretty well with a few blips along the way. There was some restrictions there. However, I am pleased to say that at the end of last month we had over 9,000 patients, new patients recruited, and we've got 370 GP practices across the country recruited as well. So we're well on way to our target. However, those numbers are perhaps not just as up to date as they should be or could be, simply because during the last number of months, obviously priorities for teams have been elsewhere. So next slide, thanks, Joe. The objectives very clearly there, expand and accelerate the use and adoption across primary care initially. That was the main focus. We wanted at least 50% of our practices using it, and we wanted a large-scale redesign of hypertension, and we brought in those management pathways that you'll hear more about for diagnosis, medication management, and the long-term monitoring. And that's where the focus has been originally for the scale-up blood pressure. However, our partners had indicated that they could see further use within secondary care as well. And you see there we had that nearly 9,000 new patients, as I say, but health warning on that one is that's probably not the true actual total of new patients there. So we're on our road now, and it's I'm pleased to say that last month we had 600 new patients enrolled. So we saw in June alone quite an increase there, and hopefully that will just start to increase. Thanks. Next one, Stu. You'll see the partners right across there. We've got most of the board areas involved, and I have to also say that pending is probably NHS Orkney, potentially for Shetland as well. The ones in red are the ones who were not successful for the funding. That's not to say they're not doing something about blood pressure monitoring, but they weren't successful in the funding for this particular programme. However, we're always open to some new partners coming on board, and it should be pointed out that Inverclyde had made significant progress in actually getting some test of change funding, and had recruited all of the 100% of their practices in East Renfrewshire, I should have said, my apologies, to actually this programme as well. So it's not been all doom and gloom by any manner of means, and we're seeing really good progress happening there. So next slide, thank you. Florence Solution, most of you will be familiar with this then, and all I'm going to say is this is our legacy system. This is where we've started with in the last 2 or 3 years. In fact, some areas have been using it a lot longer. It is what it is. It's simple. It's text messaging. There's no other option to it. We do get the automated reminders. It is a very straightforward. It's easy for the patients to use, and I like it. We've managed to get that reports into Document, but there's reports on PDF or Excel for the staff, and it's quite easy to change scheduling as times and so on. The validated protocols are there. The patient, it's free for the patient to text, but we have to pay for the license and the text bundles at the board level. So that's where we came from, and that's what most of the partners at the moment are using. Move on. We've had challenges and opportunities, particularly in the last 3 or 4 months with COVID, but also before that. So we had a previous culture where patients and clinicians kind of felt as if, oh, well, it's all right, but you know what, I can just simply still write down, get the patient to write down their blood pressure and come in, and patients sort of felt, oh, well, I don't really need to do that. I like going and seeing my doctor or my nurse. Changing priorities clearly in the last few months have seen a resurgence and a change. Okay, somebody's got their put their phone on mute, thank you. And record integration has been quite a challenge for us. However, we're now seeing a difference here. We've got a Once for Scotland approach. We're making sure we've got some resilience here against all of the challenges that are coming across the piece as staff and clinicians stand up their services again and resume some sort of normality, at least as far as looking after our patients. So we really need to see what we can do to support that. And I think we have to embrace the opportunities here, and hopefully you'll hear more about that today. Thanks. So I'm going to introduce Richard Forsyth now, who's going to tell us, as it says on the screen, why blood pressure is important. Thank you, Richard.
Thanks, Morag. As Morag kindly said, my name is Richard Forsyth. I'm the Health Service Engagement Lead for the British Heart Foundation. And our role within this work has been, obviously, as you imagine, blood pressure and hypertension in particular has been of huge importance to the BHF since its inception almost 60 years ago, but also predominantly through our new strategy to 2030, where it's one of our key roles in terms of looking at high-risk conditions. Blood pressure is obviously one of the key things that we want to focus on. And 2 to 3 years ago, we launched a funding award that we were going to fund a number of projects across the UK looking to specifically tackle hypertension through the kind of detection, diagnosis and long-term management of that condition. a lot of the work was predominantly based around about the Public Health England health check model, but we were aware from the context and the landscape in Scotland that wouldn't fit. I had been actively involved over the years with Keepwell, and although that wasn't exactly the same as the Public Health England health check model, there were similarities, and we're quite keen not to go back down that route, but look at where we could add value to a project that was scalable, and Scale Up obviously was that project. It was gathering momentum. It's done some excellent work in Lothian, Lanarkshire, and Western Isles initially, and it was a really good opportunity to add some value to that and build it up. So if I could just move on to my first slide. What I was looking to do was try to give some context and set the scene about the importance of blood pressure monitoring. Naturally, it has a huge impact, not just on the individual's health and risk, but also the health system across primary, secondary and community care. Blood pressure is the leading modifiable risk factor for cardiovascular disease, and it's actually implicated in half of all strokes and heart attacks. So what that does say, there's a huge opportunity here to make a difference, both in terms of the system, but also that person's risk. Naturally, what it does is it increases their risk, not just of cardiovascular disease in terms of stroke and heart attack, but also developing conditions such as heart failure, chronic kidney disease, vascular dementia. And it is also a common risk factor amongst other long-term conditions such as diabetes. And having those comorbidities of combining things like hypertension and diabetes really does increase the risk of that person going on to suffer sometimes a fatal event. So it really sets the landscape of answering the why question. Why is this something we want to tackle head on? But we look at the impact on society. So if we move and kind of almost pan out from the individual to look at society, roughly 30% of the population in Scotland is perceived to have high blood pressure. So it's not a small problem we're trying to tackle. It's a huge impact across that health system. And there's a large number of that 30% that are undiagnosed. They're walking about with what's commonly known as the silent killer. So there's that huge opportunity where we can make a real inroads and make a real difference. I suppose one of the quite stark statistics that's been pulled out from some of this work is that even of that percentage that we know about and has been diagnosed with this condition, only approximately 27% of those people have actually had their blood pressure treated to target and control below 140/90. And why is that? So I mean, we can hypothesize it's a multifaceted element, but there's a lot of components that come into that and are in play within that. Partly could be medication compliance and concordance. It could be education. It could be the system, the way it's set up to support people with this condition in terms of how they're diagnosed and supported in terms of long-term management. And that's even before we start to overlay some of the more complex elements such as health inequalities. So there's huge elements at play within this, but what it does do is it provides us an excellent opportunity. One thing that we're cognizant of in terms of the models that we then try to support and scale up is the impact it has on the system. We're very aware that primary, secondary, acute, tertiary care are stretched, and that's pre-COVID, let alone the impact that COVID's had on the system. So when we look at blood pressure and how it's currently monitored and has been over the past few years, in excess of 1.2 million appointments alone in primary care is used just to solely measure blood pressure. So if we play that impact back into some of those statistics, when we look at 30% of the population have high blood pressure, of which a significant percentage have not been diagnosed, if we go out and find these people, that's great. We've increased our detection rates where we can then start to manage and support those people. But if we just plug that into the current healthcare system, that's going to have a huge impact in terms of workload within primary care. The system is obviously bursting at the seams because of all these competing priorities. So we have to look at something that's going to streamline and obviously help manage those people that are currently in the system, but potentially those excess people that's going to come into the system as well. So something like Scale Up, which Brian's going to go into a lot more detail of, can show where there's some real opportunities to support that, not just going out and finding these people with hypertension, but supporting them in terms of long-term management and ultimately treating them to target. That is a common goal, to reduce the risk of any acute event. I suppose the slightly concerning thing about hypertension, now we're aware obviously the complexity of it and importance of it, is within Scotland there was no real national strategy or drivers to tackle this head on. Yes, it was muted and mentioned in other white papers and government strategies, but there was nothing specifically targeting this. And back in, I suppose, towards the middle to end of 2018, as part of the cross-party group with British Heart Foundation in partnership with other third sector organisations, developed an inquiry process to really look at what was the key drivers and what was the key recommendations we wanted to make around about hypertension. And one of those key things that came out when it launched in Holyrood back in January 2019 was to create a national task force. And thankfully, Brian, along with Professor David Webb, is the co-chairs of that. And it really looks at how we can tackle this head on, and it's put together some key recommendations to do that, one of which is scale-up's been looked at as an exemplar model. Now, I know the way this has been presented, it looks at quite a bleak picture in terms of what we live, but it's not that at all. It really highlights a great opportunity to make some real inroads in terms of improving people's health and reducing their risk. It's an excellent test bed for innovation, and one of those is scale up. If we look at some of the impacts that's been seen in countries such as Canada, the way that they've increased their detection, medical management and medication compliance rates has been excellent, and the impact it's had in terms of risk and reduction of secondary events has been phenomenal, and that's something that we're obviously aspiring to and moving towards. One of the elements, if I can just move on to my last slide, is before we go in and talk about the model and scale up as well, I think the model in terms of delivery of primary or secondary care is great, but we need to look at how we kind of wrap that round the patient's understanding, their information and the support that we give them. And what we've done at BHF, in addition to supporting this project, is just recently in the last week launched a Manage Your Blood Pressure at Home hub with some support and resources. So we're well aware that the clinicians are the expert in this field, the practice nurses, the GPs and others that spend the time talking through the importance of blood pressure, what it means to you, but we're also cognizing that everyone has a different learning style and retains different amounts of information and at different times. So what's been launched in support of some of this work is this hub that people can access free of charge at home, and it shows videos to how you can measure your own blood pressure, but what impact you can have to directly support that change in blood pressure in terms of diet, physical activity, salt, etc. So that's just been recently launched in the last few days. So I'm going to pass over to Brian. I believe it's going to talk a lot more in detail about the model, but it's just to say there are loads of elements there as the wraparound support to really make sure that we can have the patient at the heart of everything we do to help them not just be detected and diagnosed with blood pressure, but really support them to make a difference in this area. So I'd just like to pass over to Brian now.
Okay. All right, thank you very much. So I'm Brian McKinstry, and I'm the Emeritus Professor of Primary Care eHealth at Edinburgh University, and also the clinical lead for this programme. Could I have the first slide, please? So I've got quite a lot of slides here, and I'm going to rattle through them. So they will all be available at the end if you think I've gone a bit too quickly. So this is just reiterating what Richard said. It's a very big problem. A huge amount of the 1.2 million appointments in Scotland are just for measuring BP. They don't actually take into account all the other times that we measure blood pressure in general practice when people are in for other appointments as well. But the most important thing here is that given the age distribution of the population and the increase in long-term conditions, the number of people with high blood pressure and the number of appointments required are likely to double in the next 10 or 15 years. So next slide, please. So how do we cope with this? Just click through this, thanks. So one of the ways we can do this is through self-monitoring. Actually, if you go back, see, maybe this is just not working very quickly. There we go. So a lot of people have suggested that self-monitoring alone is a good way of dealing with this. And it does to a certain extent. People who self-monitor get as good results as people who don't self-monitor, but they actually feel a little insecure and they do not consult any less than people who monitor, and yet the results aren't better. And so there's been a drive towards telemetrically supported supervised monitoring. So next slide. So does this work? So we carried out a study in Lothian a few years ago now with 400 people with uncontrolled blood pressure. And we demonstrated very clearly that those that were telemonitored had lower blood pressure at the end of 6 months than people who didn't. And we followed that up with studies in diabetes and in stroke. And this has also been subsequently supported by a systematic review of 14 international trials. And they all show the same thing. It's now unassailable that telemonitoring improves the management of blood pressure. And when it's been modeled against its impact on cardiovascular disease, it suggests that it's cost effective as well. So the next slide. One of the problems that we have with this is that although clinicians liked it, they had to log on to a separate website to see the results. It took time, particularly in a busy surgery, and a lot of people didn't do it. And so we have had difficulty in the past, and all over the world, people have had difficulty in scaling up telemonitoring. And the doctors in our study suggested changes which integrated this care with their own working practices to make it more efficient. You give me the next slide. And so that's why we invented Scale Up BP. And this was a simple system based on text reminders. So that's the Florence system. Any mobile phone can be used with this system. But the big difference was that from the Florence website, the data was extracted and converted into a report. And that could be at a frequency of 1, 3, or 6 months, depending on how well the patient was controlled. So it was sent by a DocMan, along with routine practice results and hospital letters, etc. No need for the practice to log on at all. But the website was available at any time for more frequent checks. So next slide, please. Next slide, please. So this is what it looks like. So you've got a report which shows in graphical and tabular form how well the patient is controlled. And it gives an average of the last 5 readings, and very, very clearly lets you know if the blood pressure is out with limits and whether or not you need to reconsider either adherence to medication or maybe changing medication if it's out with limits. Next slide, please. So this is just a little graph of how it took off. It started off a little bit slowly and then it's taken off. And as Morag said, this is much, it's taken off across Scotland and these results are much better. Next slide, please. And patients really like it. And it's, in fact, it's almost every patient who uses it likes it. And this slide, of course, is out of date as well. There are now 9,000 people across Scotland using this. Next slide, please. So patient engagement was interesting. So the dropout rate in the first year was only 7%, which is very, very low for any sort of implementation at all. So patients really did seem to like this quite a bit. As you can see, these are the number of readings that people took. And some of the average was around about 1 reading a week. But you did get the odd person there who was a little excessive and doing 10 readings a week. So they're a little bit more on the worrying side, and you probably want to take them aside. But in general, people use this very sensibly. Next slide. So this is interesting. If we look at the difference between the first and the last reading, there was a difference of around about 6.5 millimeters of mercury over a period of time. This is in the scale up set that we looked at. But if you looked at people who weren't using Scale Up, and same number, the people in the same practices that weren't using Scale Up BP, they had a drop of around 3.5. So a fairly substantial difference between these two groups of 3 millimeters of mercury, which is quite a lot really, and enough to reduce the stroke rate by about 12%, MI rate by about 8%. Next slide, please. This is just an example of control. So patients whose blood pressure was initially uncontrolled with telemonitoring, 35% were uncontrolled, and that reduced to 13%. Similar figure for the people in control groups was a considerably smaller change. Next slide, please. Next slide, please. Could we have the next slide? Right. So also interestingly, as around about 1/3 of controlled patients in the comparator group, so these are people who were initially controlled, became uncontrolled, but less than 1/4 in the telemonitoring group did. And this suggests a possible long-term benefit of monitoring. So there might be an assumption that once you've got people's blood pressure controlled, that's it, but that is definitely not the case. And telemonitoring appears to improve the adherence to blood pressure controlling measures. Next slide, please. The number of appointments was interesting as well. If you looked at the number of appointments in the year prior to introducing telemonitoring, there was a reduction of total number of appointments. That's everything, face-to-face, and appointments that people might have made on telephone, or things in the appointment book, which might have been for repeat prescriptions, was reduced by 9%. But the total number of face-to-face appointments was reduced by 24%. So you're probably losing around about 1 appointment a year for most of these people. So next slide, please. If you look at the comparator group, those falls are much less. So in other words, telemonitoring was associated with a reduced face-to-face workload. Next slide, please. So in conclusion, a significant proportion of general practices and professionals embraced the idea of supervised telemonitoring at scale. The BP control seemed to improve in line with randomized controlled trials. And there was no obvious increase in face-to-face workload. If anything, that was reduced. There were 1.2 million consultations last year, and that is set to double. So even with Corona, doing nothing's not an option. Technology has to be the answer. Thank you.
2 years, it definitely helps her. She's aware of her blood pressure, she's aware of keeping it under control, and she's made differences to her lifestyle as well. And I think this is what's coming across, that people who are monitoring their blood pressure will start to make the lifestyle changes because they understand they really do have high blood pressure and they should be doing something about it. So we'll try and do that. Yeah, thank you for some suggestions on how we make it. I think we've already kind of tried that one. Okay, I think we'll move on. John Turville is a GP, and he's going to tell you his experience of using this, and then that'll be followed by Sharon, a practice nurse. Okay, thanks, John.
Hello, yes, John Turville. I'm a GP, obviously. I started my career as a GP in the Royal Navy for 20 years, and then since then I've been an NHS general practitioner at the Harbours Medical Practice in Cookhensey, and I'm now clinical director for East Lothian, and I'm the Lothian clinical lead for Scale Up. I got into this through some work on long-term conditions management, and then was involved in the Telescott trials with Brian and the Lothian Telehealth Board, the trials on blood pressure, stroke and COPD. The practice and myself were a little bit involved in that, and that's what led us into being early adopters for Scale Up. We've also, in terms of our practice blood pressure management, we have used a surgery pod for replacing face-to-face appointments for blood pressure case finding. Obviously, that's not in use at the moment. We've also used for years 7-day home blood pressure assessment, and had a good number of monitors for loaning to patients. So all of that has added up to hardly any face-to-face appointments being used for blood pressure checks in our practice for a number of years. As far as Scale Up's concerned, the dynamo in our practice for Scale Up has been Elaine Ross, my healthcare assistant colleague. She is an absolutely amazing champion and driver of the whole thing, and works relentlessly on it. So we now have at the practice 455 people enrolled on long-term monitoring, which I've just worked out is 5% of the national total. So we're quite proud of that, and we find it a fantastic aid to our management of our patients with high blood pressure. We are constantly trying to update our long-term conditions management, and particularly now driven by COVID, we're thinking how we can do that, how we can do case finding. So putting things on our website, particularly to encourage people, knowing that the community is quite flooded with blood pressure monitors. Most people can beg, borrow, or steal one, or even consider buying one from the local pharmacy. Encouraging people to, if they're over 45, check their blood pressure, do a few readings, and if they're above the target, then to download the 7-day home blood pressure form and actually do a series of readings, and then do the maths if they can, or send it to us to do the maths and work out whether they may be hypertensive and need a bit of investigation, advice and treatment. I'm just putting up on the chat the link to the Harbour's medical practice site, principally because one of my colleagues, Peter Churn, recently produced some videos on self-management for various long-term conditions, including hypertension. They're very watchable and short, so I'd recommend having a look at those. For the future, moving on, one of the gaps in what we do is our practice nurses have not been very engaged in hypertension management, so we're working on that. And as I said, how to replace face-to-face case finding at the practice. We're going to have a drive on that and publicize that. My only caution based on experience with this, and it's probably well understood by a lot of you, is that this sometimes is not a tool for everybody. I've had to take a small number of people off it who are inclined to overmeasure, over-obsess, and worry about individual readings out of the target range, and reminding people that this is a long-term condition and isn't about this week or the next month. It's about long-term risk and risk management. But for most people, it is a fantastic tool. I think that's about all I've got to say. I'm trying to keep within my time, but at the end, happy to join the panel and answer questions.
Thank you very much, John. And just to reiterate, I was really pleased that you brought up your healthcare support worker, because my next speaker is Sian Ghani, who's one of our practice nurses in Lanarkshire. And I have to say that certainly from Lanarkshire, and I believe on most of our partners, would find that we had not done scale up blood pressure without our practice nurses and the other practice staff, including pharmacists and healthcare support workers, actually helping us with this, and they tend to be seeing the variety or the majority of the patients, and taking again their share of the workload. So welcome to Sharon. Thank you very much, Shan, and over to yourself.
Hi, as Morag said, I'm Sharon Ghani. I'm a general practice nurse practitioner in Lanarkshire. So I've been using Florence blood pressure monitoring since sort of early 2016. There are 5 nurses within the practice, 2 new nurses, and we all manage the hypertension patients, and we all use the Florence system pretty easily now. But it wasn't always like that though. When I first started using it, I found it quite overwhelming to cope with. I had all these patients sending in blood pressure levels that I had to review and manage, as well as keeping on top of the usual day-to-day clinics. So I would get into the Florence website every day, usually at the end of my shift, have a scroll through all the readings and then think, right, I'll deal with that tomorrow. And of course, tomorrow was as busy as the day before. So what I hadn't considered was how I would find the time to do all this extra work. And that is what most nurses, that's the kind of query that they have, how we're going to manage this on top of everything else we have to do. So I knew the theory behind it. It was a great way of monitoring our hypertensive patients who, as we know, make up the biggest of our disease registers and therefore take up most of our time. They would no longer need appointments, especially for intensive monitoring or diagnosis or treatment changes. The white coat hypertensions, well, they would all recover because they wouldn't be in a clinical setting. I could text them messages rather than getting no answer on the phone. numerous times. So what wasn't to love about that? So my plan was to set out when and how I would follow these patients up. So although they're not taking up a face-to-face appointment, they do still need time put aside at an appropriate interval for you to deal with them. So Florence has now got set protocols. So for example, if you want twice daily blood pressures for a 2-week period, you set that protocol up and then add that patient into an appointment slot for 2 weeks later on your rota. Use a telephone slot or an admin slot, just somewhere that you'll be able to see on that day that they need their review. For those of you using Vision and where you use Daybook, we have set up a task, we call it Florence, and we set the date that we want it to remind us, and whichever nurse comes to that, who's got time on that day, they will go in and deal with it. So in that way, if you're using the Daybook, your rota's still quite clear, you've not got all these patients in it. Now with COVID and reduced footfall, we tend to deal with the Florence patients when we get a few minutes, maybe between patients or between phone calls. But it's a good idea to set aside time, 10 or 20 minutes, protected time to review these patients. And I've found that patients can be reviewed, treatment adjusted, a message sent to them, and a new protocol reset in less than 10 minutes without them even leaving their house. So since using this system, follow-up has been so much easier to manage. So the number of patients we can manage at a time has increased because they don't need appointments. They do the BP in the comfort of their own home, and they text them in when they get a reminder. The patients do find it much better than having to come in for an appointment. Many of them work. Many of them have other health problems, which can make it quite difficult for them to attend. And all this results in patients getting into their appointment and their blood pressure being high. So how many times have you had letters from outpatient clinics asking you to monitor someone's blood pressure because it was high and their procedure could not go ahead? And it was high because they were stressed and worried about what they were there for, but they need monitored and then quite often re-referred, and you know, that could all have been avoided. Secondary care clinics like renal or cardiology asking you to increase somebody's medications because their blood pressure was high in clinic may be absolutely fine the rest of the time, or if they do need it increased, we don't need to see them as much as what we normally would have done. So it means you don't have to see patients weekly for monitoring or drug titration. A quick phone call, explain to them how Florence works, get their permission and add them to the programme, and you select the protocol you want to follow. So a lot of the time patients' blood pressures return to normal, don't require any treatment. That's the bit the patients like, and us of course. And then the next time they're going to the secondary care appointment, you can print out all their blood pressure recordings to take with them. And also, as was mentioned, Florence now sends all the blood pressures via DocMan, so you've got a running spreadsheet of all the blood pressures they've sent in. Some of the elderly patients that we've got, that's another thing. Oh, how are the elderly going to cope with it? Most of them cope absolutely fine. A lot of them have got phones, mobile phones. But I do have patients that have enlisted the help of their son, daughter, grandchildren, and they just tell them what their reading was, and then they do all the texting. So it's open to almost everyone. There's also a self-management plan which details the levels of blood pressure and what to do depending on the results. And there's some health promotion information on there too. So I hope this has been helpful and answered some of your queries. And I would like to conclude by saying it's a great step towards people managing their own health condition. They're taking the responsibility for their monitoring and working in partnership with the healthcare professionals, and hopefully that will improve their confidence longer term in managing their health better. So thanks for listening.
Thank you so much, Sharon. You've been one of our greatest advocates across Lanarkshire, I have to say, and really pleased that we've actually got about 90% of our practices in Lanarkshire signed up. So absolutely brilliant, and Sharon's been a real support to us all along and says it as it is. Loved that quote, Sharon, what's not to like. Yeah, I think a lot of patients would agree with you. So thanks very much. I think just to sum up, Joe, if you want to give the next slide there. I think it's important to think about this. Just to very quickly point out, we do have that next generation. Our partners tell us we need a system that going forward, we want one that really can be that multi-channel, giving visual feedback to the patients, not just the text messaging, and absolutely connects to existing systems. So next slide, thank you. Yep, just going slow now. Next one. Thank you. So just to also point out, we've done that procurement, as I say, and there's a national procurement underway for a much better improved system. However, we have got Florence at the minute, and we'll try and use that. Areas that don't use Florence, it might well be that we might provide something or suggest something else. We are pleased because we have got Florence as a tried and tested system at the moment, so I would certainly put people in that direction. We have also, as I said, extended out to perinatal care, so it's blood pressure and urinalysis for mums being shielded and at home, trying to reduce again the footfall. Thank you. Next one. And it really just to sum up, saying why use tech? Well, we're showing there is that improved patient experience. We're actually reducing the footfall, we're raising that awareness, so even if you are still having to see patients, you can perhaps reduce some of the times that you're going to see them. We can save up to 4 or 5 appointments, and particularly where, as I said, diagnosis and that medication titration. We can reduce the travel and costs there for both staff and patients. And, most importantly, at the moment, we're reducing that exposure to infection. And I think it is there for sure. I'm happy to take questions now. I think that's really us. It is over to yourselves. So thank you. I think that's the last slide, is it, Joe? Yeah. So I'm really very conscious that unfortunately we were a bit slow there getting started. So I'm just looking to see what there is there. Costs, the funding went from, as I say, to the partners who were successful in their applications to Scottish Government. That was 11 partners who were funded for 2 years for the programme. At the moment, the Florence system, the licence is purchased by the boards and administered by that. And there is quite a significant cost to the text bundles. That's why we're looking at a strategic procurement, which will be funded by Scottish Government in its entirety. So we have made efforts to try and bring on as many partners as we can on this one. For individual GPs, that would be quite difficult because the cost of the licence would be a bit too much. Patients can use their own machines if they are. We use British and Irish Hypertension Society validated monitors, and that's for domestic use, and they actually are getting they are at quite low cost for people if they want to buy their own. We are not recycling the monitors at the moment, and we're taking into account that the partners that have been funded, we may have to provide more monitors. The low cost of the monitors would make it absolutely not feasible, especially just now, to have that increased footfall for monitors being returned. At the moment, we've a contract that actually gives us the monitors at £12, so not really. However, as Sharon's saying, we can encourage them to buy their own if they're able to, but if not, we're not expecting them to be recycled at the moment, and certainly probably not in the longer term. I think it's a move from the diagnosis and titration to the longer term, as I was said. Yeah, if you're not getting monitors, then get back to your tech team there. So is there any other questions coming through? I'm trying to just catch what's going on. Any hands up for anyone? Yeah, the British and Irish Hypertension Society have an approved list for monitors for home monitoring there, and we were very strict when we did the national procurement. We've got those on a national framework, which anyone in the health service can access in Scotland. We made that available to all health board areas. It went to your procurement leads. If you have any difficulty with that, if you get in touch with me, I can forward you, or the team, we can forward you on that one. So definitely there. Fife did not secure funding. They did secure funding, but unfortunately, but we were decided not to proceed with that one. So I would point you back to your own eHealth colleagues in Fife on that one. They declined to continue with the Scale Up Blood Pressure programme. I think there was some issues there, so I don't want to say more than that, but it's an internal part there. The monitors not requiring calibration, that would be your own clinical decision whether you feel that monitor is suitable for use. That would be your clinical decision. So Orkney, we've got a conversation I'm having. We've already offered Orkney to apply for some test of change funding there. Debbie Crone and Kerry Lowe are aware of that one. We've had looked at BP monitors on prescription. That's not as easy as it might sound. We certainly looked at that probably about a year or two ago. The difficulty with that is that would then probably put the price up, but not only that, it has to be one provider that approaches Scottish Government and asks for the monitors to be put on a prescription, believe it or not. So yeah, there's health inequalities and issues with literacy. That's always a problem, but as Shannon has said, sometimes there are family members or someone else that can do that. Grampian, you have a tech team in Grampian, and certainly if you get in touch, we'll give you the tech you can get in touch with. Large cuffs, yes, there are extra large cuffs for that particular monitor, but have to be aware that the monitors, I think it's a maximum cuff available for most of the monitors available on sort of usual script are up to 45 centimeters. Anything larger than that comes into a very expensive model for the particular monitors that do a bariatric supply. A cuff for extreme bariatric is then needs a monitor suitable for that, and it becomes very expensive. We did some scoping to try that. Grampian, yep, you have got flow up there, so hopefully we can put you in touch. Anyone else? I'm just working my way through everything. I think certainly, some comments earlier on was about, of course, we're not saying this will replace everything, but, yes, you can, as Sharon says, perhaps get a better handle on all of that. The Greater Glasgow and Clyde were in discussions. I know that's been raised at your primary care meeting, I think today possibly, with Lorna Kelly and is it Lorna Kelly from your primary care is bringing that up. We were trying to encourage Glasgow to take an NHS Glasgow across. So yeah, we're hopeful there. If Fife want to get together and lobby and come back to us, we'll be very welcome. Erica. Thank you. My apologies. Yep, Erica, I've been pointing people back. I'm sorry, I forgot you were on the call. So for Grampian, Erica Skinner's on this call, and she's the tech lead for Flow in Grampian. So please, she'll be delighted to welcome you. Western Islands, I think again, there weren't not enough of an interest there, and that happened, but there might be something else again, and we could look at something different for you in Western Islands. And Ian Trainer, certainly Western Islands, when they were involved with the when we were involved with the blood pressure scale, the BHF work we did a couple of years ago, Western Islands was involved in that one, but there were some issues there. So Sharon's told you copy and paste the message function, but like everything else, you can actually, just as if the patient was in front of you. It would be, Tanya, it would be your eHealth. Joe, remind me who it is that we've just had the conversation about, Fife. The lead, the contact there. If Joe can remind me. All right, I'm trying to see. I've got brain freeze as far as names. The shelf life for the blood pressure monitors, they're validated for 2 years, but usually what we see at that, the low cost, if they don't work, you stop, you just replace them. You know, that's, you soon know they just stop working. They either work or they don't work. And again, this is for home monitoring. It's not for, you know, high end there. It's just taking, this is better than somebody not getting the blood pressure checked at all, by a long way. You know, so I think, as Sharon's saying, your patients who historically will not come in to the practice, who are your 0-hour contracts, your lorry drivers and so on, then, you know, this is so much better. Fiona McLaren is no longer in the eHealth lead in Fife for Florence. She was moved to another role, so it would be someone else, so we'll get that there to you. Okay. The monitors, as I say, we've not had terribly many monitors not working. We just replaced them. We've really not seen that as a great issue at all. It would be over to your own local procurement. It's what they can manage with and how they want to do it, but it's certainly been. So thank you, John, saying the monitors being inaccurate with AF also have been dispelled. I think that's really helpful. And it's interesting that we're seeing more and more now, because secondary care have stepped down their ambulatory monitoring, then it's not, you know, it's not a requirement there. You know, they're discovering that they can actually do an adequate diagnosis on Florence having up to 14 readings within the 7 days or 14 days. The 20 readings will give silver level. It's not, and you will still need ambulatory monitoring for some patients. That is your decision, but it's interesting how many are not going down that route now, and that's saving the patients that double visit to hospitals. Okay, Forth Valley. Forth Valley. Oh, remind me, Joe. I'm absolutely brain freezed. Thank you, Emil Whitfield. Yeah, and we've got, if I remember, it's Emma Hotop. Okay.
Yeah, it's Emma Whitfield and Karen Hotop.
Thank you.
You're welcome.
Thank you. So I'm going, we're 3 minutes over here. If there's no more questions, I'd really like to thank you so very much. We've had probably about over 200 people at one point on here. So please do get in touch with us. There's the email, and we're more than happy to try and either point you in the directions or indeed answer any of the questions or get you some help there. Thank you very much indeed. So good afternoon, everyone.